Good evening, everyone, and thank you for joining us for Season 4, Episode 10 of Doc Talks with Dr. Forrest Tennant and friends. We have special guests tonight and a lot to talk about, a lot to go over. Dr. Tennant, I'm going to go ahead and let you just get started. We know time is precious, and so is our time together. Thank you so much.
Yes. Thank you, Jamie. To start off this evening, we're going to start with the bad news first, and then we're going to get to some real good news. But the bad news is that this week I had 2 or 3 people inform me that they went to pain clinics to get some help. Now, these were, I think one was in the Northeast, one in the South Central, and they went there and they had adhesive arachnoiditis. And they went in and saw the nurse practitioner or the PA. I think that's who you see these days. And neither one of these professionals knew or had ever heard of adhesive arachnoiditis. Now, this is frightening. Now, it's frightening because how you could not know about adhesive arachnoiditis in this day and age as a professional astounds me. But to be working in a pain clinic and not know what this disease is dangerous. Now, let me get to the danger point here now. And I've got a feeling we got a lot of people watching here tonight who have been victims of something. I want to tell you, let's cover, for those watching this, you know what adhesive arachnoiditis is. In case you're new, you're not, but adhesive arachnoiditis is when the bottom of your spinal cord, called the cauda equina, they're nerves that hang down, become glued by adhesions and inflammation to the wall of the canal. Now, when that happens, that is a dangerous, dangerous disease. It only happens it's very unusual. Some people call it rare. But the point is, that is such a dangerous thing because it's a mass. If you go to a chiropractor and that chiropractor doesn't know what that is and pulls too hard, he'll pull the mass apart. But what's bad about this is that these clinics don't know that when you have that mass in the spinal canal, you've got no business getting an epidural. You've got no business getting a blood patch. You better not go to a surgeon unless that surgeon absolutely knows what that is. But all these people who went to the pain clinic, the first thing they recommend is an epidural, some other kind of a shot, some kind of a blood patch, some invasive procedure, which is absolutely contraindicated. I mean, the idea that you might have adhesive arachnoiditis and somebody's going to put a blood patch in there, inject blood into the spinal canal, try to do a spinal tap even unless it was a life-saving emergency? You've got to be kidding. That's why we've got people walking around out here in wheelchairs, bedbound, debilitated, because somebody didn't know what that disease was and decided to manipulate the spine. Now, I'm here to call on everybody who's watching this. We're kind of a family here on this program, but I'd like to call on everybody who's watching this to be a self-appointed educator. When you go to your doctors, I don't care whether it's a cardiologist or a pediatrician or a proctor, I don't care. Would you tell them what adhesive arachnoiditis is? I mean, I can't believe that we have pain clinics in this country with professionals who are licensed not know what that disease is. There's no excuse. Okay? And if you've got adhesive arachnoiditis, you've got no business taking an epidural. If they're going to put a pump in you to pump morphine into you, look out. You're headed downhill because you're sticking a device right next to that mass. So you don't want that until you really are in trouble. Okay? End of the road. If you think you're going to die pretty quick, you may want to try the pump. I hate to put it that way, but that's the way it is. Okay, so that's my sad story for the week. I don't know what we do about this ignorance, this dangerous ignorance, but nevertheless, it is out there. Now let me switch to some good news. I know that a lot of you have heard me talking about the Epstein-Barr virus, and I have been studying this intently for a long, long time. When I first got into pain treatment clear back in the 70s, do you know who my first patients were? They were post-polio patients. And I kept saying, this polio, they're supposed to be over, but they've still got pain in their legs or their arms or their chest. There's something wrong here. That virus hasn't quite gone away. Well, I don't know whether it was still polio or whether they had Epstein-Barr virus. I don't really know, because in those days we didn't have any testing. We didn't understand viruses. We didn't know much, but they sure had pain. And they sure looked to me like they had something alive still in them called polio. But anyway, I could go on and talk 50 years of litany, but I'm going to stop right here and tell you the good news is that tomorrow my studies and my book goes online. On Amazon in the next couple of days, you'll be able to buy this book. Okay? Now, it's going to be cheap because I don't care about the money. It's just breaks even. It's $15 or so. But it's called The Epstein-Barr Virus, a New Factor in the Care of Chronic Pain. Now, why is this good news? It sounds kind of awful, like we're just bringing another virus or another malady or another complication in, but that's not what this is all about. We now know that the Epstein-Barr virus is why most of you watching this deteriorate. We now know that causes autoantibodies, even in such diseases as rheumatoid arthritis and systemic lupus, and it sure as heck does in people who have EDS and these other risk factors. In other words, for those of you who have deteriorated, gone from ambulatory to bedbound, it's probably Epstein-Barr autoantibodies. Okay? Now the understanding, and all I've done is taken a lot of brilliant research over the last 30, 40 years, figured it out. We've been doing studies of my own for quite some time, about 20 years, in fact, and studying these different viruses. And this is the Epstein-Barr virus, the lead virus. Okay, now there's some other viruses out there that contributed to it, such as cytomegalovirus and the herpes 1 and 2, rubella, COVID, and what have you. But Epstein-Barr is the big one. But here's the good news. We can control this virus pretty easy. And a lot of you do it and don't even know you're doing it. But the bottom line is we can improve the care of pain patients. We can reduce pain in almost everybody, anywhere from 10 to 50%, if they just know how to work with the Epstein-Barr virus. So what am I getting at? I'm going to talk about who should be tested. One of the things that's come out of that and in the book are the 3 tests that your doctors need to order to understand whether you have Epstein-Barr reactivation and autoimmunity. Okay, now, you just heard me say something. It really should be called a disease. Epstein-Barr virus reactivation and autoimmunity. Okay. Now, this is considered a rare situation in textbooks. However, in the patients we've been testing, not at all. I don't believe you can adhesive arachnoiditis unless you have Epstein-Barr reactivation and autoimmunity. Let me repeat that. I'm not sure you can develop adhesive arachnoiditis unless you have either Epstein-Barr reactivation and autoimmunity, perhaps another virus, but you have to have something that stimulates inflammation inside the spinal canal. You have to have something that degenerates your discs. You've got to have something that provides glue to glue your cauda equina to the wall of the spinal canal. So what I'm getting at, we now know anatomic what is the generator. But just remember one thing, when you leave here today, leave here with this message. Something has to cause the inflammation to make your disc degenerate, to give you a Tarloff cyst, to give you a leaky spinal cover with a leak. You've got to have something that generates inflammation inside the cauda equina and the arachnoid lining. And we've known that you had to have a generator for a long time. We didn't know what it was. But there's been some, I won't go into details, but it is in the book, a little summary of how different research this out, and all I've done is add to it with my own studies. So, again, for the next sessions, you're going to hear about the Epstein-Barr virus. Why? This might shock you. The last major breakthrough in pain treatment scientifically was about 10, 15 years ago when some real bright researchers, particularly a woman by the name of Dr. Linda Watkins from the University of Colorado, then you had a real bright brain scanner by the name of Abkarian from the University of Chicago. They determined that glial cells activated and caused inflammation in the brain. What they didn't know was, why did the glial cells activate? They didn't know. But the next big breakthrough, I will tell you right now, in my opinion, the next big breakthrough of this century is the knowledge that the Epstein-Barr virus can reactivate in adults and cause an autoimmune disease. That's our big breakthrough. Now, most people are going to say, oh, Epstein-Barr, oh, we know about that. That's just a kissing disease. It causes infectious mono. It's been around for a long time. We're not going to worry about it. And that's exactly what your doctors are going to tell you. Oh, we're not going to worry about Epstein-Barr. Who ever heard of that causing anything? Guess what? Go take the test and you'll find out a real shock if you have some of these painful diseases, okay? As a matter of fact, let me just tell you one thing. Most people who develop Epstein-Barr reactivation and autoimmunity, the first thing they start with is fibromyalgia, okay? Or maybe a migraine headache or a carpal tunnel or something like that, okay? That's where they start. Okay, a couple of other things about the Epstein-Barr, because I want to get everybody somewhat educated each time. I'm not going to take the whole session. Let me again talk about what we mean by reactivation. That's a term that is new. It's going to be new to your doctors. It's going to be new to your psychologist, your chiropractor, your minister, everybody you come in contact. Nobody is going to know what that term means. Okay? Yeah. Now, reactivation means that you acquired the Epstein-Barr virus probably before you were 2 years of age. Now, some acquire it when they're teenagers or young adults when they get infectious mono. And incidentally, if you've had infectious mononucleosis, your risks of developing RSD, fibromyalgia, Tarloff cyst, adhesive arachnoiditis, intractable pain go up immensely. So right now, if you've got pain somewhere and you've ever had infectious mono, you better have these tests as soon as you can get them, okay? So what does reactivation mean? When you get this virus, it's you get the sniffles usually as a baby. But the virus goes into your lymphocytes and it goes into your throat membranes. And it stays there as a normal parasite. Now, 95% of adults have had exposure and will test positive that they've come in contact with infectious mono. Okay, I do, you do, everybody does. However, if your immune system has ever taken a hit, then that virus is just waiting there to reactivate. Now, what do I mean by your immune system taking a hit? Listen carefully. If you were born with EDS or Marfan's, you've already taken a hit. If you were born with scoliosis or spondylolisthesis, you've got a spinal column abnormality, you've just taken a hit. If you've ever had a bad accident, and that's why a normal person can have a bad auto accident, fall off a roof, get tackled too hard in football, perhaps a domestic violent episodes, military combat, and you may have had that accident, and guess what? You've taken a hit, but you didn't know that you activated the virus, but you didn't know that, maybe for 20 years. Also, psychological, if you've had a real traumatic thing in your life, maybe a divorce, maybe a financial, maybe a child died, something that's really, really tough. I'm talking about, something really terrible. We're not talking about our usual ups and downs of life. We're talking about a serious psychological event that wears you out. PTSD, for example. something really serious, that's bad. It's trauma, psychological problems. Also, let's say that you've had a situation in your life where somehow or another you were deprived of sleep. You couldn't eat right for a while. That's bad too. In other words, you activated the virus. Now, let me go on and give you the thing that we've discovered, which is sad. Reactivated Epstein-Barr virus is like diabetes. You don't know you have it until something bad happens. In diabetes, all of a sudden you may have a heart attack or your kidney fails or you've got a leg ulcer and you didn't even know you had diabetes unless you took a blood test. That would tell you. With Epstein-Barr, the reactivation can go on for years and it's asymptomatic. You don't know you have it till you one day you wake up with a cancer or you wake up with a pain problem. Got that? You go on for a long time, maybe years. You don't know you have it. But you wake up with one of the cancers. Epstein-Barr virus is now known to cause 2 to 5% of cancers, a lot of them rare. Okay? So I talked to a couple of patients this week who've developed cancer due to Epstein-Barr. Or you start a painful condition. Okay? And that painful condition might be fibromyalgia to start with. It may be 2 or 3 slipped discs. It may be that your spinal cover starts leaking. You don't even know you have this. Now, what happens during reactivation? Now, here's the other thing that I want you to know, and I want you to educate anybody you can about this. When the virus reactivates, it does 2 things we know of. First off, it invades your tissues. Okay? The virus starts growing. So all of a sudden, your lymphocytes are carried through the blood to your glial cells in the brain, your cauda equina, your discs, maybe your muscles in your chest, maybe your carpal tunnel. In other words, the virus can get carried in and invade your tissues. But the second thing it does, and here's what's hard for people to understand, it creates what we call autoantibodies. Now, we've known for years that we can control things like rheumatoid arthritis or like lupus, Sjogren's syndrome, a lot of these autoimmune diseases, but we couldn't cure them. And that's because of the autoantibodies don't go away. And that's why if you don't control those autoantibodies, those of you who are still walking might end up in bed. Those of you who are in bed are going to die a lot sooner than you should because those autoantibodies eat away tissue. They just keep eating away at it, causing your pain to get worse. You don't get better. You wonder why. You're taking your medicines. You've got a pump in. You go to chiropractor. You do everything you're supposed to, but you keep getting worse. Why? Unless you know to control the autoantibodies and how to control them, you just slowly deteriorate. That's the bad news. Now, let's give you the good news, though. The Epstein-Barr virus can be controlled quite well, and even the autoantibodies can be controlled reasonably well. Okay? The inability to cure a lot of our pain problems is those autoantibodies. We now know that's the biologic mechanism that's been haunting all of us for years. We just didn't know. We do know now, though. Okay. Now, the first thing you want to know about the Epstein-Barr virus is that there are 3 measures to try to control the virus, and we're going to teach you the main one here right now. It's real simple. A lot of you are doing it and didn't know you were doing it. Okay? Now, it turns out that the virus inside the lymphocyte can be sort of stopped from growing. Okay? And there are several researchers who are under laboratory conditions have determined a number of simple supplements that keep the virus from replicating, from reactivating. So you can stop the reactivation. The problem is the autoantibodies that are still out there or the tissues that's been invaded. Anyway, I'm going to show you. Now, there's references for this. They're in the textbook. Therefore, if anybody asks you about this, you can go right to the scientific references, tells you which laboratories, the scientists who did it. But there's about 7 or 8 simple things in which doctors have been using them for years and we didn't know why. It just seemed to work. Okay. Now we're going to show you right here. All right, now here is a list of the supplements that have been shown in laboratories to stop the virus from reactivating. Okay? And I'm going to read them to you. Plain old vitamin C. Okay? Plain old vitamin C. Plain old vitamin D. Resveratrol, luteolin, astragalus, selenium. Turmeric is supposed to be on there. Zinc, lysine, selenium. Okay? Simple stuff. They're in the book. And what I recommend is, first off, you know what? I'll tell you my favorite reactivator stopping, and that's plain old vitamin C. I mean, I personally recommend that people who test positive for Epstein-Barr take 2,000 milligrams of vitamin C in the morning, 2,000 at night. And I like selenium is one of my favorites. A lot of doctors like zinc better. Lysine's been an old-time favorite. Resveratrol is dynamite. Okay. Anyway, these are things that stop the virus from reactivating. I think you ought to be taking 2 or 3 of these. You don't have to take them every day. They're cheap. Now, if you stop the reactivation, pretty soon the virus that's in your tissues will die off. Okay? And as long as you're not making any more, you're going to get better. Okay? That's why a lot of people all of a sudden, they start taking vitamin D, they start getting better. They start taking resveratrol, they're getting better, and they don't know why. Why? Because they're stopping the virus from filling you up more. Okay? Now, a couple of other things that you should know about the Epstein-Barr virus. One of the things we've been talking about on this program for a long time are peptides. When you take those peptides, and my favorite peptide for this virus is thymosin, but I also like BPC 157, KPV, AR290, collagen supplements, colostrum, all the things we've been talking about build tissue. When you build tissue, you drive out Epstein-Barr. Okay? Remember that. Build tissue, drive out the virus. All right? So, if you have a pretty good program of taking some of these, you're taking some peptides and some colostrum or DHEA, some of the things that build tissue, you're on a pretty good program to start with. Okay? Now, let me now cover the last thing I want to cover, because we're going to cover this more next week. You have to know, and your doctors are going to have to know, which 3 tests you have to take. Okay? Now, if your doctor tests for Epstein-Barr, 9 times out of 10, he'll order the test for infectious mononucleosis. You don't need that. What you need are 3 tests. There's 3 tests that have been developed to determine if you have active reactivation or had reactivation in the past. And if you have current reactivation, you're going to have to go on antivirals, in my opinion. Okay? So, now, in our studies of people who have gone all the way through pain and one thing or another down to adhesive arachnoiditis, 70% have active reactivation. Not everybody. Now, those who do are going to need to take, in my opinion, corticosteroids and antivirals. Okay, so you need to test to find out, do you have current reactivation or do you just have the autoimmunity? Now, they're both bad, but you can control the autoimmunity fairly well too, okay, with things we've talked about. Now, next week, I'll talk about more specifically the tests you've got to order, and you need to carry those 3 to your doctor, because your doctor's not going to know. If the doctor looks up tests for Epstein-Barr, guess what? Laboratories like Quest, LabCorp, and what have you have got about 8 different tests. Okay? So which one do you order? There are 3 that you need for our purposes. Now, those other tests are needed for certain things like transplant patients and pneumonia and hepatitis and some things, but that's not what we're after in pain. We're after knowing whether you've got reactivation and autoimmunity and whether your pain's going to get better or worse. Anyway, I want to wrap this up. It sounds kind of awful in a way, but it's really pretty simple. It's new, but I can tell you that if you get on a program, people should be able to, number one, stop a lot of their deterioration. Okay? Stop the deterioration. Remember, that's number one. Number two, don't let the pain get worse. Okay? It's bad enough as it is. Let's not get worse. If you don't control Epstein-Barr virus, your pain is going to get worse. I don't care how much opioids you take or who you're going or whether you got a pump in or not. You're going to get worse if you don't control that virus. Okay? So you can do yourself a lot of favors real quick and real cheap and with that. So I want you to know that it sounds awful, but it's really quite good news. It's new. You got to think about it for a little bit. We're going to try to keep the books nice and cheap as we can, and they'll be on Kindle and what have you. And I do recommend that you get it. Now, let me close off one quick thing. Who should get tested? If you have chronic pain, defined as you've had a pain over 90 days and you've got to take daily medication to control it, you better have the Epstein-Barr test. Okay? You better be tested for reactivation and autoimmunity. Okay, that's the educational part of this program today. You'll hear more about it because it is, I consider it, frankly, one of maybe the biggest breakthrough in my career of doing this work for 50 years. So I like to say it's different, but it is good news because it's simple. We can deal with it. We can help people real quick.
I have some more good news.
Good.
All of us doctors have had cases that have puzzled us throughout our careers. This has been a 50-year puzzle for you, and thank you for sharing it with us. The good news I have for you is if your doctor has called you crazy, or if your doctor has blamed you for your illness, or no one can solve it, you've got Epstein-Barr virus.
That's right.
And you needn't tolerate any bullshit about how you're nuts and you don't have this and you don't have to put up with gaslighting anymore. The mystery is not yet over, but we have a place to start. You can start at go, roll the dice, get around the board, stay out of jail, get to free parking, and maybe make some progress in your illness. So we've got a place to start.
Thanks so much.
Great news for those of us who are floundering. Thank you, Dr. Tennant.
Thank you.
Well, you said last time something that, and do you know, until I got into this, I did not know that Hodgkin's disease.
No, me neither.
Okay.
Yeah.
I remember doing chemotherapy. I used to do a lot of cancer work. In fact, I got into the pain field by doing pain work in cancer patients. Not one person ever said anything about it. And guess what? It was right there in the literature. Right there. Now, most of it was British, but it was right there. And I feel kind of ignorant. In fact, I feel kind of sad because we could have helped a lot of people then. So I don't know whether there's any cover up. I don't know whether it just fell through the cracks, unbelievable, or whether that's the nature of science. I don't know. All I know is we got a grasp now. Okay, we got us a tool.
That's right. Dr. Tennant, thank you for that. If you don't mind, we've had a couple who have asked about the 3 tests. I don't know the answer. I know one is the early EBV. Would you mind naming those 3 tests for us, please?
Not at all.
Thank you.
And incidentally, whoever named them ought to be shot. Actually, a wonderful couple by the name of Henley named these tests. And what they are, they're 2 antibody tests. And in fact, it's kind of fun to learn about this. It all makes sense. One antibody is called the viral capsule antibody, abbreviated VCA. Okay, VCA, viral capsid antigen antibody, VCA. Now that one will tell you whether you've had reactivation. It won't tell you how many times, because incidentally, you can reactivate these things just like you do a herpes. Okay. Now the second antibody is called the nuclear antigen antibody. Okay. NA, and it's abbreviated EBNA, Epstein-Barr nuclear antigen antibody. Okay. Now that's, if that one is high, that means you're carrying a lot of autoantibodies. Okay. So that's the autoantibodies. Now the one that every pain patient needs The key one, the most important one, is what they call the early nuclear antigen. Okay? Now, on your lab slips for your labs, if you just use the word early, you're probably going to get the right one. And next week, I'll try to have a little more on about it. In fact, I want to teach a lot of you here how to interpret it. I mean, they're not hard, but it's like learning to drive. If somebody doesn't show you, it's pretty tough. But anybody can learn to interpret these things. It is going to take a little doing, but this is the kind of thing that all of us have had to learn how to interpret a cholesterol test or a glucose test or a white blood count test. But it's far less complex than a white blood cell count. Okay, a blood count. So it's not hard. It is new, but it's not hard to interpret it. And there's not a soul watching this show that can't learn how to do this and to do their own interpretations. Okay. But the early one is the one that you want to be negative. Okay. If you get that one from positive to negative, the others always stay high because they're antibodies. But you want to try and get that one to negative and what have you. And incidentally, one little sidebar, a lot of doctors I've talked to are kind of happy about this because they feel hopeless a lot of times. This way, they know they can give you some Valtrex twice a day, famciclovir 500 milligrams twice a day. It's real simple. I had one patient this week who takes Valtrex twice a day when she has flares. She keeps some around, takes it when she has flares, and it works. Okay. So, okay. Jamie, we have an important guest, I think.
Yes, we do. Welcome, Dr. Parker, everyone, please. Welcome to Doc Talks. Thanks for being here.
Thank you very much. I appreciate it.
Yeah. Dr. Parker, first
Pleasure
off,
to meet you, sir.
Pardon?
Pleasure
Yeah.
to meet you, sir.
Oh, nice to meet you. I will say this. You're here by popular demand. A lot of people know about your situation, and they've lobbied me and Mark to get you on the show. And
Thank you so much.
Let's just say right out front that I'm so regretful you're here under the circumstances that you're here. I've got a lot of things I'd like to ask you, but I'd like to open it up really to you, for you to tell us, not only, I know a little bit about your background, but I want you to feel free to tell us in your words who you are, what's happened to you, because I'm a little astounded on what people have told me about you, and so I want to hear it from the horse's mouth. Okay? So take it away.
Yes, sir.
Tell us how you got here and what's happened to you.
Yes, sir. Well, I was born in Kansas, but I grew up in rural Arkansas. My biological father had a car wreck, and my mother married a very kind farmer from rural Arkansas. So we moved there when I was about 2 or 3. Arkansas is what I've known and grew up in. When I graduated from high school, I wanted to go to college, but being from a farm family with about 10 kids, I knew I had to find a way to do that. And I joined the United States Marine Corps. And while serving on active duty with the 1st Marine Amphibious Brigade, I was able to finish a degree in computer science. That allowed me to apply to the Air Force. And the Air Force had doctors. Marines don't have doctors. The Navy does, but by then I had a family and didn't want to be out on a ship. So I applied to the Air Force. I served in the Hawaii State Sheriff's Department, the Civil Division, while I waited for the Air Force to have a slot. And then I trained at Lackland Air Force Base in San Antonio, and also at for my officers training, and became an Air Force officer and an ICBM commander while I got my prerequisites for medical school done, because that's really what I wanted, was medical school. After 3 years of active service with the 12th Strategic Missile Squadron in Montana, I was accepted into the Mayo Clinic, and I graduated with honors in '97 and went into emergency medicine. I also worked in emergency medicine, or studied emergency medicine at Wilford Hall Medical Center in San Antonio, at Wright-Patterson Air Force Base in Ohio, at Scott Air Force Base in East St. Louis. That was an interesting place to do emergency medicine. And then I did a surgical rotation at Keesler Air Force Base in Mississippi when it still existed, before the hurricane took it out. And I had, every life has ups and downs, mine probably a little more than most. But I became the director of emergency medicine and trauma at 2 hospitals. I had started doing primary care clinics probably about 2006, I believe, and started working with a board certified pain specialist so I could understand that condition more. It's necessary. The state of Arkansas expects all primary care doctors to treat chronic pain in their patients. It's mandated by law, actually. And so that was something that I did. And like I said, I spent a decade with a board certified pain specialist to make sure that I knew what I was doing. I traveled to Harvard and took courses called pain management for the primary care physician, and started running a comprehensive primary care clinic with an elderly doctor, Dr. Donald Duncan. He was in his 80s. He was wonderfully brilliant and extremely knowledgeable. And he and I took care of everything that came in between his surgical and emergency skills and my emergency skills and primary care skills. There really wasn't anything that we couldn't handle. And we had oncologists sending us patients, pain specialists, and we would do the primary care management after the specialist had set up treatment. And that seemed reasonable to us. And we, of course, I started medical school in '93 when the pendulum started swinging toward actually treating pain. And then the pendulum started swinging back about 2010. We adjusted. 2016 came out and the CDC guidelines, we adjusted. So we really were not worried about anyone targeting us, but our clinic did end up targeted and shut down. A patient of mine was pulled over for a traffic infraction, thrown in jail because he had 1 trazodone out of its bottle, and they withheld all his medications, including benzodiazepine. He begged for them, they refused. He actually pounded on the cell walls, they still refused. It's all on video. And then he started seizing at about 5:30 p.m. after about 6 hours of incarceration. They saw that he was unresponsive and wouldn't wake up. They didn't call for help. They waited an hour. He was still unresponsive an hour later. When the new crew came on, they called for help. By then it was probably too late, but when the EMTs arrived, he still had a heartbeat, but they gave him Narcan saying he died of an overdose, that he was dying from an overdose. Of course, the Narcan did nothing. He had taken his pain medicines 20 hours before, the night before his travels, because he was traveling up to see a spine specialist that I had sent him for. And so they didn't tell him that they had tell the EMTs they had withheld his benzodiazepines, and the seizures caused him to have heart failure, and he died on arrival to the emergency room. So rather than prosecute the jailers for depriving him of his constitutional rights, I was targeted and prosecuted for treating him in the first place. And the argument that that I had placed him at a high risk of addiction. And even though the coroner said that he had died from heart failure, the government was willing to try to give me life in prison by saying that I was responsible for his death. I went to court and fought them. To a degree, I won. The jury was convinced that I was not responsible for the death, but they did fault me for treating him at all, because the government throws out these vast numbers that seem overwhelming to a jury or even to the judge, that without context can be very convincing. So I'm looking at 7 years, 3 months in prison. I will report in 3 weeks and start serving my time.
Unbelievable. Can I have a couple of questions I'd like to ask. Were you tried now by a federal court or by a state court?
Federal. Arkansas has a state law that says a physician cannot be prosecuted for treating pain, even if they use dangerous medications and dangerous combinations, which is really the job description of a physician: safe medications and safe combinations over the counter. But so it was federal.
All right. Now, what I'm getting at, can you explain to me and the audience the process on starting with the open bottle, to get into, I mean, the person who prosecuted it is a federal prosecutor,
Right.
U.S. attorney, appointed by some president. Okay?
Right.
How did the federal prosecutor, this political appointee, end up with your case?
They have an AI that combs through prescription monitoring programs and any online medical records looking for what they consider, quote, overprescribers. And they have confused the average practice of medicine with the usual practice of medicine. So physicians willing to treat the sickest patients will
That's right.
often have the outlier prescribing practice. So one pain patch for a cancer patient can be 225 morphine dose equivalents. Well, there you go. Now you're more than twice over the CDC's recommended caution. But the DEA has taken the CDC's voluntary guideline and turned it through an involuntary criminal enforcement mechanism into an absolute mandate. And that's not what the CDC intended, as they clarified in the 2022 clarifications, which, by the way, came out 2 weeks too late to save me.
Okay. Now, and so you went before a jury. How many people on the jury?
There's 12 people on the jury. The government was able to get a toxicologist to say that my medications had caused the death, but they could not get an MD to. They could get an MD to say that his opinion was basically the standard of care and that he never prescribes, I think, more than 2 5-milligram oxycodone for cancer patients a day. And so my practice was unusual. He also went so far as to say that he could tell from the MRI that the patient didn't have as much pain as I said they had, that a veteran with spinal fractures should never have been treated by the VA, and I should have recognized that.
Now, this is an MD. This is not an MD.
This is an MD. He said that an EMG was read wrong by the neurologist, and I should have known that, and just implied to the jury that I just didn't know anything.
So I have to go then?
Yeah.
Okay.
Can you get
Okay. Now let me, but in other words, the experts who they brought in, one's a toxicologist and one was an MD?
Yes, sir. The MD spoke about the usual practice of medicine, legitimate medical purpose. He argued that if I was worried about addiction, then a patient had addiction. Now, understand, I was certified to treat addiction. I was certified to treat. I had gone back to Harvard for training. I opened the first Suboxone clinic in this area. I had done everything you possibly could. 14% of my prescriptions were Suboxone. So it's not like I was ignoring addiction or didn't care about it. I traveled once a week out of town to treat addiction in another town. But once their AI points at you, they look for an excuse to prosecute, not a reason.
Yeah.
And nothing you do will dissuade them from trying to make you look guilty. And I testified on my behalf. And so did Dr. Alan Wartenberg, a brilliant addiction expert who wrote the chapter on avoiding addiction in the principles and practice of pain medicine. He was there for me despite prostate cancer. So I will always respect him for that.
Now, let me ask you another question that I'd like for our audience to know. Who was the federal prosecutor or curators who tried to prosecute you? Do you remember his name?
Dak Keys was the United States attorney. He had to resign because he was caught, according to the papers, sexually harassing his workmates. So he had to resign, and it was taken over by another gentleman. I don't remember his name. The assistant United States attorney that prosecuted me, her name is Ann Gardner, and she had prosecuted 3 other doctors in Arkansas, including a Dr. Hinderleiter, who at the age of 81 was sentenced to 10 years in prison after pleading guilty. And he died.
Now, let me ask you a question. What president appointed her?
That's a very good question. I would have to look and see. She may go back to Clinton's time. She might be Asa Hutchinson. I would have to look and see.
Okay. The point is that I want to make.
I'm naming governors. I should be thinking presidents. Yeah, I said governor. Asa Hutchinson's a governor. It could have been Bush. It could have been Clinton, but I'll look back.
Yeah, here is the point I want to make. Everybody comes on this program and everybody talks about CDC, FDA, and DEA. Those people don't make any decisions. All they do is work for the political structure.
Right.
And I hope you don't mind me taking this
Please.
approach, but it is time that people know that the DEA is working for those prosecutors. FDA doesn't do anything. They've got to have a federally, politically appointed prosecutor to go after a doctor. Now, who is the judge?
Well, I hate to name the judge publicly. I'm still kind of under her purview.
Well, that's all
Let's
right.
just say she was appointed by, I believe, Barack Obama. I feel like she tried to be fair. I feel like the federal system has taken almost all authority away from judges. I think the prosecutor controls everything.
Well, they pretty well do, don't they? Yeah, the point I'm getting at is that all the pain patients and everybody now thinks that it is the federal agencies has the war on doctors and on pain patients. It's not.
Well,
These prosecutors have been appointed
that's
by
right.
both Republican and Democrat presidents, and they report to the Attorney General and the President of the United States. It's a direct line of command.
That's right. And one of them said, we need to go where the money is and the guns are not. I think they've given up on trying to fight the cartels, and they have kind of a Christmas agreement, sort of like what happened in World War I between the Germans and the British, where they said, we'll bomb you at 2:00, you bomb us at 4:00, and none of us will get blown up. We'll all know when to expect it. I think that they have to know that what is causing all of the deaths is fentanyl poisonings and xylazine poisonings from illicit drugs coming across, the commercial checkpoints. So if they really wanted to save people, they would be at those checkpoints stopping the inflow of fentanyl and xylazine. But it's hard work, and you might get shot. When you kick in the door of a doctor's office, none of them have fired a gun yet. Everything's laid out in the open, and the prosecution is so simple. Confuse the jury with false metrics and lots of numbers. Pay an unscrupulous doctor to get up there and just say that what you did was wrong. The jury has no context. There's really no similar trial. If it's a financial crime, the jury will have some context. Did you forge a check? Did you do this? But what is the usual practice of medicine? I mean, the Supreme Court acknowledged that they didn't know. And so they just listened to arguments and make a vote. Well, that's like a patient with chest pain coming into the ER and me rounding up 12 random people and saying, hey, I'm going to argue that you need a stent, and I'm going to ask Dr. Tennant to argue that it's heartburn and you need to go home. We're going to let these 12 people vote, and whatever they decide, that's what we're going to do.
Now, are you going to appeal your case?
Yes, sir.
You could. Mark, are you there and have some questions, or Jamie, either one?
Yeah. The prosecutor you had first, his name was Dak Richards.
Dak Keys, Keyes. His first name is something else, but he's known.
He's
known as Dak.
There's a YouTube video of him that is really incriminating to him.
I have seen that. He said in the video, you can go after the doctor, you can go after the wife, because the spouse always knows. And I just wanted to ask him, really, Dak, does the spouse always know? Right. Because I bet yours didn't know.
Yeah,
but anyway,
not what he was up to.
No.
Yeah.
No.
Yeah. I would definitely like to hear from Dr. Neil Anand and give him a chance to add to this, if you could, and would, Dr. Neil.
Dr. Anand is here?
Yes, he sure is.
I'm here. Hi, everyone.
Hi, welcome.
Nice to meet everyone. I've known a lot of people. Either I'm friends with them on Facebook, and I've seen all the work that you guys are doing, and I'm real proud of you guys, because I've seen so many faces here, and you guys are doing so much to try to change things in the United States for the better. And I'm sure you guys are discouraged at sometimes, but you guys keep fighting on, and I just love it. So thank you guys so much every day for what you guys are doing. It gives a lot of courage to the rest of us. And if you guys weren't around, I mean, I think a lot of us would have given up hope. A lot of the doctors would have given up hope if the patients weren't around to help us. So it's just wonderful to see everything. And uh, I think it's a good community, and it's the way people are being treated on is like lepers, honestly. Like in Rome, I would see Ben-Hur and see that movie, and they would show, Jesus going into talk with the lepers and everything, and or even Ben-Hur, and so it was to me. It's just it seems like we're repeating history in the ways that we're treating people is very similar to the ways they were treated in the past. And there was a social hierarchy in the past, and it seems like we're repeating history once again. So thanks for having me on, and I'm be happy to answer any questions
Well,
about
I've got one.
anything. Go ahead.
I'm the ranking man. I've got a question.
Sure, go ahead, sir.
You just said the thing that bothers me. Where did this come from that we're not treating humans decently? We are not giving, a fair shake to doctors. I mean, we're hearing that it's like we just assume you folks die, and they're not, and they're, and there's a real animosity against doctors. I mean, you just heard it. I mean, what's going on here?
Well, I'm here to explain it and make it clear for everyone because I wanted to get accurate information because what was going on is when you talk to people or you hear stories, you'd hear multiple different stories, but in my mind, I just knew a lot of physicians in my life and history, and I just know that there couldn't be so many doctors that were criminals or were just so, deviant, just because I went to medical school and, I'd been exposed to a lot of physicians and so I just knew that it didn't, the reality of the situation didn't conform to my personal experience and what was happening. So I filed a lot of Freedom of Information Act requests from all the agencies, DEA, Health and Human Services, Department of Justice, even the Solicitor General. And then I would not get many answers back from them. And so then I would sue them, or I would appeal them, and then I would sue them in court by myself. And we'd get documents slowly, and now we've figured out basically the history of where all this came from, when it exactly started, when the databases were made, what they're trying to measure in these databases against people, but basically, using computers, and I'll explain you a little bit about that because, when I grew up, I grew up in upstate New York, and Dr. Parker said he was a computer programmer, but when I was a kid, Apple II came out, and I actually got an Apple II computer. My father bought it for me, and I learned how to program on that and the Commodore 64, which was a little bit before that at the local library. And equations are very hard to essentially equations of human life, essentially equations in physics, essential equations in chemistry, in finance, and mathematics. There are numerous of them, but there can be simplified in in a book, or it's a small number. And there are a lot of computer programs, and the computer program, as Steve Jobs said, should be a bicycle for the human mind. And we've asked the government, okay, tell us how your computers work, what you're programming in those computers, and what you're actually measuring in patients and doctors, right? How are you determining a good doctor from a bad doctor? How are you determining a good patient from a bad patient? And the government is collecting data every day on patients, either from the prescription drug monitoring program. They measure a bunch of factors: the dosage a person's getting, how often they get it, what pharmacies they're getting it from, how far do they live from that pharmacy, how which doctors are prescribing to them, how many doctors are they seeing. So they're collecting data, how many different controlled substances are they on, what is the dosage MME of controlled substance they're on. And what the whole point was the government wanted to collect all this data to categorize people, to create a score, a social score, a score about someone, and to categorize people, whether they're good patients or bad patients, good people or bad people, they're going to good doctors or bad doctors, right? Because that's the whole purpose of their computer program, because that's all it can do. Does that make sense?
Yep. It not only makes sense, could we ask you another thing?
Yes.
We're about to run out of time. What I'd like to do is have you back.
Sure, I'd be love to come back.
I have a personal thought. When I started doing pain work and addiction work, it was law enforcement, including DEA, the ones who got me to do it. We were partners, and this goes back in the 70s. You've been tracking this. I'd love to hear you maybe give us a little chronological tracking on what's happened. I'm mystified as to this ugliness that we've come into. And you sound like the one person who's studied it. Would like to have you back next week as soon as Jimmy can get you on. And would you give us a rundown? And I'd like your personal opinion, anybody else's. I think we need to kind of go back. What went wrong here? I mean, I think you're right that we're repeating some history, but we're actually punishing people. We're sending people to prison, sending people to their deaths. I mean, this is not the way that humans are supposed to treat each other. I know it's as simple as that. This is ugly stuff. Okay. Anyway, thanks. I appreciate what you've done, because you're one of the few people who've really tried to get to the bottom of this, and I appreciate it so much.
And I want to do it with proper information from the government, so people don't debunk us and say, hey, these guys are conspiracy theorists, or hey, these people don't know what they're talking about. Actually, no, I've studied a lot of medicine, a lot of science. I did the first heart transplant in Philadelphia. I was on the team that did it in Philadelphia, Thomas Jefferson University Hospital. And then, I served in the U.S. military in terms of the U.S. Naval Medical Corps. And I've seen a lot of soldiers who, lost limbs or had a lot of, physical trauma to their bodies and mental traumas as well. And so what is happening in American history right now is it's a tragedy. And I would love to come back on and talk with everyone.
Okay, thank you so much, Dr. Parker. Our prayers are with you, and our hopes, not just for you, but you have come to symbolize the very worst of what's going on. And please appeal. I don't know what we can do, but
we can testify.
Yes. Can we help with an appeal for you? Is that a possibility?
Well, I used the last of my life savings on a very, very good appellate attorney, Mr. Ron Chapman. He fights very hard, former Marine and Judge Advocate General Officer. And so I will be hoping for good things, but stoically ready in case I don't get them.
And what address do we contact you at?
If you go to BOP Inmate Locator, if you just type that into Google, you can type in someone's first and last name, and it will tell you where they are, how to reach them, how to send an email to them. I looked it up so I could warn my family, and I guess they've incarcerated enough people now that they have to make it more convenient. So it's very nice.
So do we look you up under Lonnie Parker?
Yes, sir. LONNIE.
Okay.
When I was stationed in Hawaii, I had to quit using that. It means beautiful in Hawaiian. I had to let that go.
Well, you are.
I named my oldest daughter Lonnie, and it fits her better. But thank you. You're very kind. I appreciate it.
Good. Thank you again, and God love you.
Thank you, Dr. Tennant. We appreciate you and everything you do.
We are with you every moment.
Thank you, sir.
Don't forget that.
You betcha.
Thank you.
When we say you are not alone, it's not just because we like to say it. It's not a cliche. You truly are not alone. You have countless people who not only are with you, but we care and we're here and we're not going to walk away from you.
Yeah.
So
Thank you.
please know that.
Thank
And
you.
we
I'm
are
so
mad as
proud.
hell, and we're not
So
going to
we're-
take it
we're-
anymore.
Thank
Hey.
you. And I'm so proud of Dr. Tennant for speaking out for the patients who are told that it's all in their head or they're just crazy. Frustrated doctors make bad decisions. Frightened doctors make bad decisions. Dr. Tennant, what he's doing is extremely helpful. These people aren't making things up. Just because we can't find it, that's our failure, not theirs.
Great. Okay. Good luck.
Thank you, sir.
We will see you again.
Thank you. Yes, sir.
Good night.
Soon.
Thank you.
Thank you all so much. Does anyone have anything they'd like to add? Just if they can do a 30-second, anybody just want to add anything towards the end, even if it's a prayer, anybody at all?
I want to thank these doctors from the bottom of my heart. For once, we are being heard.
Yes.
We are being told we're not crazy.
Yes.
Thank you from the bottom of my heart.
Yes.
Yes. Thank you for telling the truth.
Yes, thank you
so
for your service.
Denying the truth is denying of life.
I
That's
have
right.
tried to get the swab test done to see if I tabulate the opioids, and nowhere in Florida will do it. They're telling me it's a cheek swab, and none of the clinics do cheek swabs.
They're misinformed, and we'll get that straightened out for you. I just had a blood test done this week too. It's the second one I've had to show the rapid metabolization, etc. And it's a blood test, so they just don't know yet, but we will show them. It'll be
The
on
other thing you could do, Brenda,
Uh-huh.
is if you can't find this test anywhere, you can do 23andMe or Ancestry.com and ask for them to check your CYP 450 metabolism status. And it's a special add-on, so it's more expensive.
What is
But-
it?
Let me mention something very quickly.
Thank you,
Please
doctor.
do.
For
Thank you.
about $399, someone can get their entire genome read. And then you can run it through these different filters as we identify more and more genes. I know it's expensive. Insurances should cover it for every human being that wants it, but it must also be kept absolutely secret and private, which is a problem in today's with today's governmental intrusions. So,
Yeah.
but that is something to consider also.
Well done. Well said.
I do believe that's something called sequencing.com or some I don't remember the name, but it's like DNA sequencing.
Yeah,
If you
full
look up
genomic,
something,
full genomic sequencing. Yes,
that's
ma'am.
it. You got it. Thank you. Yes.
Barbara Engel also has
I had
tests you can do online and send it in.
Exactly. Go ahead, Cora. Did you have something that you needed to add?
I had 2 genetics tests done, and they were both done with the cheek swab. PM me on Facebook. I can
Okay.
look up the companies that I got it
Perfect.
done with
Thank you, Cora.
and tell them
okay.
the names of it.
Perfect.
And
Excellent.
then maybe
Excellent.
they could say who could perform the test.
Perfect. Leanne just mentioned it's called GeneSight.
Dr. Parker's book up. He's unmuted, so I'll let him speak.
Yes, it's called Perspectives in Pain. It is a light read. It is only 780 pages. So it's 180 pages more than Dune. So if you want to know what doctors and patients are facing kind of from a physician's perspective, I tried to make it to where people who don't have your problems can understand the problems you're dealing with and the problems the doctors are dealing with as they try to fight this. The federal war on American medicine probably will not win me any fans in the federal system, but it's on Amazon, and it was a labor of love, and if you read it, I hope you enjoy it.
Yes, and Dr. Parker, as a thank you and as a token of our love, appreciation, we will add that to our link tree so that people can automatically find them just with everything else that's on Doc Talk's link tree. So it's all in one place, if that's okay with you.
Absolutely, and thank you so much.
You're very, very welcome. It's the least we could do. We are here for you.
Thank you.
You're in
Thank
our
you.
prayers.
Yes.
Yes, ma'am.
Definitely. Yeah.
God bless you.
Thank you so much, sir.
Dr. Anand too, because he's not done.
Brilliant man. Brilliant man. The only one who understands the AI that they're using to target physicians and patients. The DEA accidentally left a target list at my office of about 300 of my patients. So they aren't just using this data to target doctors. They're targeting patients also.
Lord have mercy.
Yeah.
Mm-mm.
Okay.
God bless you.
Yes, God bless all of us. And like Dr. Ibsen says, God bless us, each and every one. I just want you all to know that regardless of what the situation, circumstance, or the fight is in front of us, we've got this. We've got this because the Lord is with us wherever we go. You always try
And please remember that shame is a bankrupt emotion used to dominate the vulnerable.
That's right.
And so we're done with shame.
That's right. Hold your head high and be proud of the fight that you've given.
Yes.
right. That's right.
Thank you.
You are also very loved. Up to there, at one point we had 47 in here tonight, and that is, if you put that number of people in a classroom, that's quite a large group. But even if only one had showed up, it doesn't matter. It's just the fact that the togetherness and the community, the family we have here, this will spread across like wildfire. And I pray that this show has opened up some eyes, that people understand that they could be in this boat in a blink.
Absolutely.
Pain is not a respecter of persons. It, like Dr. Ibsen says, it rains on the just. Pain rains on the just and the unjust, and the red, the blue, and the purple. So
yes,
it's a terrorist, and any of us we could fall victim to it. I want to remind us, we're not victims. We are survivors. We're fighters. We're warriors, and we will not retreat. I love you all. God bless you.
Love
God
you.
bless you. Amen.
Good night, everyone.
Love y'all.
Good night.
Stay
Thank
strong.
you
Happy
all.
birthday, Jamie.
Thank
Happy
you, Doctor.
birthday, darling.
Thank you. Happy birthday to
Happy
you,
birthday.
Carson. Happy birthday to you, Carson and Alan. Happy birthday to you both.
Thank you, darling.
Thank
Thank you too. God bless.
God
Good
bless.
night.
Thank you.
Peace.
God save the pain warriors.
That's